Yes, the first one there. The first one, the top one, is perfect. A couple of things I want to mention. It's a lot to take in. I see. Hopefully, I see some of you writing things down. There's a Boston Keraprosthesis User's Manual. So if you want to email me, my email is my last name, ALDAVE, at jsei.ucla.edu. And if you didn't get that, ask me after the session. I can arrange for you to get the Boston Keraprosthesis User's Manual. It's printed information on patient selection, setting up your OR, what instruments do you need, step-by-step photographs of the procedure itself, post-operative management, etc. And I think there's also includes publications, PDFs in it of the articles on the Boston Keraprosthesis. I would also recommend, like what I did during Dr. Basakama's DSEC course yesterday, that if you want to start a keraprosthesis program, the best thing is to watch somebody do it. Go to their OR, their OT as you call it here, and watch them do the surgery. If you cajole Dr. Tandon to come to your OR, like she did to visit Dr. Basak to help him with his first case, even better. So we know who the experienced keraprosthesis surgeons are who are speaking to you today. If you want to learn the Pintucci, Dr. Moscati may come visit you. At least go visit him. That can really help a lot as far as learning the procedure, demystifying some of these things, and also then makes them beholden to answer your emails as far as you're running patients past them that may be candidates, and what do you do if you have a complication. That's somebody you can go to. I'm always available. About every day I send probably 20 emails to India. I've emailed probably a lot of people in the audience regarding candidate patients. I'm happy to do it. So you can always email me, and I would ask you to email me or one of the other speakers regarding somebody who you think may be candidate in your practice, just to make sure you've thought of everything. Again, so now I have 6 minutes, so I will speak fast as I do sometimes. So, post-op complications, I'm going to have time to go through probably the most common ones. The first being retroprosthetic membrane. This is a vascularized or sometimes non-vascularized membrane that grows behind the optic, typically appears in the first few weeks to first couple months after keraprosthesis surgery. This is a table from an article that we have that is hopefully being accepted right now in the journal Ophthalmology regarding the use of the Boston Keraprosthesis both at my center and around the world. 223 procedures. This is the largest series of keraprostheses, as far as I know, ever put together. So probably the best resource for looking at the instance of postoperative complications. About half of my patients develop retroprosthetic membrane, and about 26% internationally. What puts you at higher risk if you're doing another procedure at the same time as the keraprosthesis? So you're taking out an ACIOL, you're doing a vitrectomy, you're putting in a tube shunt. That's associated with a higher risk of having a retroprosthetic membrane develop after surgery, as you see here. And of course, if you have a patient like this whose failed graft keeps failing because of a retrocorneal membrane, you do a keraprosthesis and it grows back, it's the same thing, but now we're calling it a retroprosthetic membrane. We don't have a significant p-value, but certainly there is an association of retrocorneal membranes with a tendency to form a retroprosthetic membrane. How do you manage this? Well, it's thought to be inflammatory, at least in part. There's some disagreement as to what causes these. If it's not vascularized, a YAG laser. Again, if you have one of these developed, just email me, and I can talk to you about the settings for the laser. If it is vascularized, I like to at least laser the part that I can, the part that's non-vascular, then take the patient to the operating room and using microforceps through a luminal incision, grab the part of the membrane that's already been cut by the laser and then pull it. You have to be very careful, of course, since this may be a pupillary membrane and traction is pulling on the iris, that you don't dilate the iris root. That's 2 points off as a keraprosthesis surgeon. So these can sometimes be tricky, but this is only something I've had to do for maybe 5 out of over 120 eyes. So not very common. Sterile corneal stromal necrosis, more likely in cases with mucous membrane pemphigoid, Stevens-Johnson syndrome. I actually do have a couple of mucous membrane patients in my practice, but they're categorized as repeat keraprostheses because others did keraprosthesis first, melted, then came to me. So when I have my tables, they're called K-Pro failures, but they're actually initial diagnosis with mucous membrane pemphigoid. And Dr. Basak is exactly right. These are I think, just as awful as far as difficult to manage after surgery as the Stevens-Johnson patients. And in these patients, the risk of stromal necrosis is much higher, but overall about 16 to 18%. If you have a melt of the donor cornea, and this is one of the more difficult things to manage, so I think this deserves some time, not all melts are the same. You've got to think about why is it that they're developing. We know that the development of a persistent epithelial defect is associated with an increased risk of developing stromal necrosis. If you have a persistent epithelial defect, 38% develop stromal necrosis, whereas only 8% if you don't have a persistent epithelial defect. Here, this is an epithelial defect present for more than 3 weeks. So in your keratoprosthesis patients, take the contact lens off at each visit, put in fluorescein, and if you have an epithelial defect that's present for more than 3 weeks, you need to start becoming more proactive. Torasorrhaphy, autologous serum, advancing a bulboconjunctival flap, covering it with something is necessary to try to get that epithelial defect to heal. Because if it sits around, you have a significantly increased risk of developing both stromal necrosis and infectious keratitis. Limbal stem cell deficiency also associated with increased risk, again, via development of a persistent epithelial defect. So as I mentioned, not all cases of stromal necrosis are the same. Sometimes it's because of desiccation of the ocular surface. In this case, it's usually going to be melting in the interpalpebral zone. So obviously the treatment is lubrication, torasorrhaphy, contact lens. Sometimes the patient will be in a contact lens, but because of corneal force shortening, it keeps falling out. In that case, put another contact lens in, but do a torasorrhaphy, a lateral torasorrhaphy. If it falls out, then guess what? You're doing a medial torasorrhaphy. You need to keep that contact lens in. If you have too much fornicel foreshortening and you can't keep it in, then just do the medial and lateral torasorrhaphy. And I have several patients after Boston Type 1 procedures in whom all you can see through the little opening in the lid is the optics. They look like a Type 2 Boston keratoprosthesis patient. And that's what's required to make sure that they don't develop recurrent stromal necrosis. Now, patients who have immune-mediated diseases, so let's say this is somebody who has severe dry eyes from graft versus host disease, or again a Stevens-Johnson syndrome patient. In this case, the melting typically is associated with significant corneal vascularization. So where you have significant vascularization of the host rim is often where you'll see some melting of the donor cornea. In that case, it's immune-mediated, so guess what? The treatment there is going to be systemic immunosuppression. Obviously, some patients may have mixed mechanisms, but it's very important to look critically at where the melting is, look at the surrounding anatomy, and think what is causing this melting in this patient. Infectious keratitis. In my experience, what I will see when a patient comes in with a very early infiltrate, and I'll show you some photos hopefully if time allows, is a little bit of a gutter that forms along the edge of the anterior optic of the keratoprosthesis where before there was no guttering. Maybe a little epithelial defect there. Often then if you look closely at the cornea adjacent to it, underneath the edge of the anterior plate, it'll be a little bit opacified. Great way to detect this is put the thin light beam right through the optic, and with a red reflex, look and see if there's any blockage of the light passage through the keratoprosthesis in that region. Because the whole cornea may be hazy, obviously, in many of these patients. But you may see a little regional increase in the density of the opacity. If you see that together with a little guttering that was not there before along the optic, be very concerned about an early infiltrate and begin therapy. Persistent epithelial defects, already mentioned, as a cause of stromal necrosis. And again, for these, bandaged contact lens wear, lubrication. I like, in my practice, autologous serum. I don't think it does much for chronic conditions like dry eyes, but I do believe autologous serum is helpful for managing persistent epithelial defects. Elevated intraocular pressure. We saw here a patient with a tube shunt. Majority of my patients, 78%, have glaucoma prior to keratoprosthesis surgery. So somebody says, well, I don't do the Boston keratoprosthesis because it causes glaucoma in a lot of patients. Well, most of these patients already have glaucoma going into surgery. It may certainly get worse after surgery, but it could, of course, get worse if you do nothing. In my series, 20% have elevated intraocular pressure. This is determined by finger tension. Okay, we don't really have good ways of measuring the IOP. So in the international series, using the Boston keratoprosthesis, glaucoma present in only 40% of eyes. But again, in my series, it's 77%. So very common comorbid disorder. Dr. Basak was spot on when he showed you that video of the tube shunt and mentioned the fact that if a patient is at high risk for developing PAS, even without a history of glaucoma, put a tube shunt in. The reason we don't do that often with penetrating keratoplasty is we're worried about mechanical touch of the tube to the donor cornea, causing endothelial cell loss. We don't worry about that with APRO. And also the concern about retrograde entry of white blood cells through the tube into the anterior chamber, increasing the risk of rejection of the endothelium. Again, not a concern with the keratoprosthesis. So in spite of the recent publications from UC Davis, with which I have some issues regarding glaucoma management in K-Pro patients, we have a low threshold for putting tubes in our patients at the time of K-Pro surgery. The decision, as you see here, whether to put a tube in or not, is typically based on the pre-op IOP. So in those in which the IOP is high, like 23.4 on average, percentage, they got a tube, and those in which the IOP was lower, 13.6, they did not. But again, anybody who I think is likely to develop progressive PAS, even if there is no history of elevated IOP before surgery, will get a tube shunt. Additional medical therapy required a minority of patients after surgery, and glaucoma surgery, as far as tube shunt, we only needed to perform in 4% of our patients after surgery, and that's compared to a much higher percentage in the multi-center U.S. study. And this is because we're more aggressive putting tubes in at the time of surgery. You do not want to be reactive. You want to be proactive. If you don't put a tube in at the time of a K-Pro, what's going to make you go back to the operating room? What's going to make you go back to the operating room is progressive cupping of the optic nerve and progressive changes in the visual field, and maybe even loss of central vision. That is not the time to do glaucoma surgery. Glaucoma surgery should be done before that happens to prevent that from occurring. So please be proactive, not reactive. Finger tension like this is the best way we have to measure the pressure. This device called the Diaton makes a lot of noises. It's very cute. It helps support Russia's economy because this is their only medical device export I know of, but it doesn't work. And that's why there's no medical devices being exported from Russia. I hope there's no Russians here. Structural evaluation. The way you follow glaucoma in these patients, you get a very good view of the optic nerve, again, barring presence of a retroprosthetic membrane. OCT can be performed quite easily in these patients, so we do this routinely to follow the nerve fiber layer thickness in our glaucoma patients, and they can easily take a visual field examination. With a Boston keraprosthesis, the vision of the horizontal meridian is about 90-degree field of view. So you can easily have that patient take a 30-degree automated visual field test with no problem. I'm going to talk about these two and then turn it over to Dr. Tandon. Infectious keratitis. 10% of the patients in the United States series, 12% internationally develop infectious keratitis. When does it occur? Well, this is the number of eyes reaching each time point. This is my series. And the times when we're seeing infectious keratitis. So we see 9 cases here in the first 2 years, and then 2 cases out 3 to 4 years. This is typically in patients who are in a contact lens. I do believe that does increase the risk slightly for infectious keratitis. These are cases that are mixed fungal and bacterial. Risk factor, persistent epithelial defect. 19% of the risk in eyes with PED, 3.8% in eyes without a PED. So much more likely to develop infectious keratitis if you have an epithelial defect that's persistent as opposed to those who do not. It's in the literature, as Dr. Mascarenhas had mentioned, that use of a contact lens and topical vancomycin increases the risk of fungal keratitis. I have not seen that in my series, but we haven't seen enough fungal keratitis necessarily to see if that's true, but I can tell you in my series, at a year, I only have about 40% of patients still in a contact lens. There are reasons to wear a contact lens. It may improve the vision, improve comfort, and protect an otherwise fragile corneal epithelium. If none of those indications is present, I typically stop contact lens wear. Vancomycin, I only use for the first 3 to 4 months and then stop it. A series from UC Davis, 12.5% incidence of endophthalmitis. What organisms? Mainly gram-negatives. I don't see that. My incidence of endophthalmitis is less than 1%, and I'm only 300 miles away. The difference in our management, they use vancomycin lifelong. I stop it after 3 to 4 months. So I think prolonged use of vancomycin may select for resistant gram-negatives on the ocular surface. As far as how to prophylax against fungal keratitis, I think it's smart to think about using pulsed antifungal topically, like natamycin. I think it's even smarter to put in 5% povidone iodine drop in the inferior fornix when they come back for their post-op visits, say every 3 months. That's cheap, as effective as we know as an antiseptic against all organisms. I wanted to skip through this. Important point. If you see an infectious keratitis following keraprosthesis surgery, it typically develops as an infiltrate underneath the edge of the anterior plate. That's how it will show up. Like in this case, which was missed by one of my fellows. Kind of a white infiltrate. It's not completely all around, and again, often associated with a little bit of an epithelial defect and thinning of the stroma immediately adjacent to the edge of the anterior plate. You cannot tell what it is by looking at it. One of these rows is bacterial, one of these rows is fungal. Which is which? You have no idea looking at it. The answer is, these are all bacterial keratitis cases, these are all fungal. They look the same. So bottom line, if you have a patient comes in who has an infiltrate just underneath the edge of the anterior plate, and you can't culture that, because you can't get it beneath the plastic. We know from the series at UCLA and the series internationally, we're seeing mixed, about 50-50, bacterial and fungal. They should already be on an antibiotic, but when you see that infiltrate, that means you need to start on prophylactic antifungal therapy. So keep that in mind. Usually some topical and or oral, depending on what agents, what organisms you're seeing in your location. Cultures are mandatory if you can. Even if I can't culture the area of infiltrate, I'll at least try to culture along the edge to see what I can get up. But if it's negative, I will continue both the antibiotic and antifungal prophylaxis. I'm going to skip through all of this. I'm getting the hook here. The last thing I want to mention is endophthalmitis. This is something which is a case from Mumbai that we had of endophthalmitis, present in about 9% in the international series, 1% in the series at UCLA. Most cases of endophthalmitis were for patients who are lost to follow-up. So very important when you're selecting candidates for ketoprosthesis surgery is a patient has a history of compliance with their medications and compliance with all of their follow-up visits. If somebody's a good anatomic candidate, but is not good about using medications or coming back when you ask them to, do not perform a ketoprosthesis for them. So cultures in these cases, we had 9 cases in the international series. I'm trying to go backwards here. Cultures were collected for 5 of the 9. Vitrus taps performed in 5 of the 9. 2 cultures positive for Candida. So even though you see filamentous fungi here in India, still the organism you're seeing causing fungal keratitis and endophthalmitis in ketoprosthesis patients is Candida. So you need to think about coverage for Candida like amphotericin. I'm going to finish there so we allow Dr. Tendon to have time to present what will be an excellent presentation on what she's learned with the OOKP and the Boston ketoprosthesis. We may have maybe a minute or two when she's done to answer questions, but probably best after she finishes so we can go outside to answer questions you might have. Thank you very much.